Multiple sclerosis is a chronic immune-mediated demyelinating disorder, but it's of the central immune nervous system. And we see demyelination in plaques in the brain, the spinal cord, and the optic nerve. So this is also autoimmune destruction. This is destruction of myelin and oligodendrocytes, and this is followed by neuronal axonal degeneration. But it's a multifactorial cause. There's some genetic predisposition, environmental exposures, and abnormal immune system regulation that comes to play. It is an inflammatory demyelination and neurodegeneration, but it's in the central nervous system. Autoimmune inflammation happens where we have autoreactive CD4 helper T cells, specifically Th1 and Th17, that cross the blood-brain barrier and initiate this inflammatory cascade. B cells and plasma cells then contribute by producing autoantibodies against myelin proteins like myelin basic protein. And then activated microglia and macrophages further mediate that tissue destruction. Demyelination starts to take place in focal areas that form plaques in the white matter, and this leads to losses of the myelin sheath and destruction of oligodendrocytes and even saltatory conduction failure. Axons initially will be preserved, but chronic inflammation can also lead to axonal transection and then permanent disability. Neurodegeneration will then occur more progressively over time, leading to brain atrophy, gray matter involvement, and cognitive decline. Gliosis can occur where we have chronic plaques developing astrocytic scarring, leading to permanent sclerosis. It commonly affects areas that, like our paraventricular white matter, our optic nerves, brainstem, and spinal cord, especially the cervical region, as well as the cerebellum and cerebellar peduncles. There are lots of different types. The most common type to know would be relapsing and remitting MS, where we have these acute episodes and which are relapses, followed by a partial to full recovery, which are our remissions. Risk factors are AFAB individual, and age of onset is typically 20 to 40. There is a genetic link with HLA-DRB1, 1501 alleles, and family history with first-degree relatives. Vitamin D deficiency and low sunlight exposure is thought to be an environmental risk factor. Epstein-Barr infection, cigarette smoking, a higher latitude residence, probably because of the vitamin D, and obesity during adolescence. Clinically, the symptoms will vary based off of the lesion location. Common initial symptoms include optic neuritis, where it's painful monocular vision loss, decreased visual acuity and color vision, and possibly a relative afferent pupillary defect. You can also see transverse myelitis, where you'll have bilateral weakness and sensory loss, and even some bowel and bladder dysfunction. Fatigue is by and large the most common symptom, and sometimes there's some cognitive dysfunction or emotional change. Brainstem symptoms can involve diplopia, or dysarthria, vertigo, or even facial numbness. Cerebellar involvement could lead to challenges with balance or ataxia or even intention tremors. Some sensory symptoms can include paresthesias, numbness, and motor symptoms like spasticity or hyperreflexia. The complication here is progressive disability due to loss of axons, bladder dysfunction and sexual dysfunction, even cognitive impairment, and visual loss can occur due to optic atrophy. Falls can happen as well as osteoporosis risk increases and advanced stages issues with skin. There's such a variable prognosis because patients have this relapsing and remitting picture. Some favorable prognosis indicators are AFAB sex, onset before the age of 35, initial presentation with optic neuritis or sensory symptoms, and a longer interval between relapses. Poor prognosis typically is when there's earlier disability or more frequent relapses, and when motor and cerebellar symptoms are present at onset.